I'm going to try to get through this as quickly as possible. It's 10 things you need to know about CSF venous fistula, both diagnosis and treatment. Um, so there's that. So the first thing that I want to say that many of us, should be aware of is that CSF venous fistulas can present with a broad spectrum of clinical findings. When we looked at our last 100 consecutive cases, what we saw is that, yeah, around 90 to 95% of patients had orthostatic headache, but many patients also had other very common symptoms, including vestibulocochlear dysfunction with Meniere's disease and tinnitus, executive dysfunction with brain fog, and then occasionally gait and personality changes as well. And what I do want to say is that there are a subset of patients that do not present with headache at all, but can present with just tinnitus or just executive dysfunction or even a frontal dementia type pattern. So very broad spectrum of clinical findings in SIH. The next thing I want to say is that the disease is actually quite common, at least in the North American population. What I've been finding is that the disease is at least as common as subarachnoid hemorrhage. As many of you know, at least in the US, the disease is primarily affecting middle-aged patients between the ages of 40 and 60 years old. It is a little bit more common in women. And then two incidence studies for CSF leak or CSF venous fistula have shown incidence of 3 to 6 per 100,000 per year. Um, when we did a study looking at 2022 data, we found the disease incidence to be 9 per 100,000 per year. During that same time, we found that the incidence of aneurysmal subarachnoid hemorrhage was 4 per 100,000 per year. So the disease is much more common than we realize. Obviously, where we live, we're showing a higher incidence because, we have more diagnostic capabilities and our whole team is very well aware of the disease. The other thing I want to say is that brain MRI findings are diagnostic, but not always present. So we're all very familiar with the diagnostic imaging findings of SIH, which include brain sag, subdural hematomas, and pachymeningeal enhancement. Um, we also see pituitary engorgement, sometimes slit-like ventricles, and then venous sinus engorgement as well. When you look at the spectrum of imaging findings, not all of the imaging findings are present in 100% of patients. So, for example, pachymeningeal enhancement is diagnostic, but present in only 80% of patients. Venous sinus engorgement only in 75% of patients. The brain sag findings are seen around 60% of patients. Now, when you look at the spectrum of findings, what this does mean is that about 15 to 20% of patients have all of the imaging findings of SIH or have a burn score of 9. And then about 15% of patients have none of the imaging findings of SIH or a burn score of 0. So it does create a big diagnostic conundrum because, we're not able to use imaging to exclude the presence of the disease. So if you see the imaging findings, you know that it's diagnostic, but it's not always a sensitive imaging finding. So here's an example. This is a young lady, very normal brain MRI. I hope my brain looks like this. Terrible orthostatic headaches. And then you look at the myelogram, and you can see that there is a very clear CSF venous fistula there. She treated and she did better. Next thing is that lateral decubitus myelography with dynamic imaging is the best way to diagnose CSF venous fistula. We've done things like positive pressure MR myelography or conventional CT myelography, and even patients with very high burn score or definitive imaging findings of SIH, the diagnostic yield of these studies is very low, less than 15%. When we started doing lateral decubitus DSM, we're finding diagnostic yield of around 70%. So there's just a nice example of a CSF fistula here on a DSM. Now, one thing that we've added is cone beam CT myelography, which has substantially increased our diagnostic yield. Um, and then we've done more and more photon counting CT myelography, which is allowing us to identify, CSF fistulas in around 80% of patients with high burn score and around 50% of patients with symptoms but a low burn score. Here's just an example of, subtle CSF venous fistulas that would not be visible on DSM when we image them with photon counting CT myelography. And I will say that our practice is shifting towards dynamic photon counting CT myelography. Then lesson 5 is that endovascular therapy is safe and effective. When we look at, several hundred consecutive patients, we haven't had any major complications, no loss of motor function, spinal cord infarction, somatic PE, spinal hemorrhage, infection, etc. Post-op pain requiring narcotics is seen in about 3% of patients. And then we do see a fair amount of technical complications, onyx emboli that go to the lungs but that are not symptomatic, probably about 5% of patients. And then venous perforation, when we're navigating the epidural plexus or in these really small, fragile veins, I've perforated a lot of veins accidentally. But the nice thing is that the pressure in these veins is very low, so never so far has resulted in a major complication. When we look at efficacy, this is important. About 58% of patients get complete resolution of symptoms. About 37% get improvement, but not complete resolution. Or about 5% get no change. We look at across symptoms across the board. Symptomatic improvement rates are similar. Around 60 to 70% complete improvement for each individual symptom, 5% no change, 10 to 20%, just improvement. What I do want to say is that one symptom that I have noted that's been kind of stubborn in terms of getting complete improvement has been the vestibulocochlear symptoms, tinnitus and hearing loss. When we look at surgery, similar outcomes compared to surgery. And also, when we look at imaging findings, one of the nice things about the disease is that we do have objective imaging findings, unlike many other headache disorders, and we see significant improvements in burn, SIH, brain sag scores with treatment, similar to surgery. So here's an illustrative case, subtle CSF fistula. This is the brain MRI before we treat it, brain MRI after, completely normalized. Next thing, I'll talk a little bit about endovascular approach. So basically, there are multiple pathways to get to different lesions depending on where you need to go. The nice thing about the venous system, especially in the paraspinal region, is that there are robust, very, very robust collaterals. So you can find multiple pathways to get anywhere. And this article is available open access in AJNR. But one thing that I've been utilizing more and more has been the epidural venous plexus. So typically what I do now is I just find a level that's close to the fistula that I need to treat. I position my catheter there and I inject hard, and then I identify the epidural venous plexus, which you can see here, which looks very much like a cavernous sinus, and then I can navigate up and down the epidural plexus to get to where I need to go. So here you can see is my catheter. I can go here, here, and then go all the way up, all the way down. I can cross midline down here. So there's all sorts of options when you utilize the epidural venous plexus. Now, not all of them are as rich as this plexus, but I will say that a majority of SIH patients, their epidural venous plexus is dilated because they have SIH, so you can actually use that to your advantage in treating the disease. But I just want you to keep in mind that the epidural plexus is like the cavernous sinus. It is a lot of septations and everything, so you just have to be, careful with your wire. So here's an example of a case where I got into the epidural plexus at like right T11 and navigated it all the way up to right T4. And this is not an exception. This is how I do the cases. So this is the patient Yeah, I'll show you right here. So first I'm getting the azygos vein, which is right above the right main stem bronchus. That's the valve. Then I bring my guide catheter deep in to the azygos vein. And then once my guide catheter is in place, I do the venogram. And then you'll see here, give it a sec, do the venogram. So when I did the venogram, I saw this is the nice big juicy vein. I'm going to get in here, come down, and then go up the epidural plexus. So you can see here the wire, and now the wire is going. It's jade at the bottom of your screen. Then I'm going to just push the wire all the way up and outside the foramen at T3 or T4. You can see the wire going up. And then out the foramen at T3 or T4, advance on microcatheter, confirmatory run, and then proceed with the onyx embolization. And this is a typical onyx embolization, but this is accelerated. Here's another one, upper thoracic foraminal veins or vertebral veins. You can see here, I'm trying to get into the vertebral vein, which is just medial and posterior to the jugular vein. And I know that I'm in it because the wire is going into the neural foramen at C6, C7. You can see the epidural plexus right here. This vertebral vein is very septated, which is pretty common. So then I get into the neural foramen, and then once I'm in the neural foramen, I'm able to go down the epidural plexus and outside my target foramen, and then proceed with the embolization. So you can see that right here. And then more and more now for the left lower thoracic ones, I've been getting into the ascending lumbar vein, which is right off the common iliac artery. And from there, you can get into the lumbar epidural plexus and navigate up as far as you like to do the embolization for CSF fistulas on the left or the right side. So epidural plexus is definitely something that you can use to your advantage. Now, talk about rebound intracranial hypertension. So it's mild is pretty common. So basically, after the treatment, the patients develop headaches that get worse lying down. It requires acetazolamide therapy in around 20% of patients. That's a little more common in women, patients with Cabrera hyperostosis or longer duration of pretreatment symptoms. Median durations around 4 weeks. We've had to do additional procedures like stenting or shunt in about 2% of patients. And then their typical dose escalation for acetazolamide. So here's the patient, severe brain sag. You can see they have Cabrera hyperostosis, which is a marker of having the disease for a long time. And then you can see here, subtle fistula. We treated the patient, brain sag resolved. A couple weeks later, developed very severe papilledema, rebound intracranial hypertension. We performed venous sinus stenting, which resulted in normalization temporarily. Then he got superior sagittal sinus stenosis. At the time, we weren't doing superior sagittal sinus stenting, so we placed a shunt. He's doing much better now. Lesson number 8 is about recurrence of multiple fistulas. So around 7% of patients so far have a recurrence at the site of treatment, so meaning I didn't put enough onyx in. It is associated with a lack of onyx penetration to the epidural plexus. So now I always make sure that at some point during the procedure, the catheter is in the epidural plexus. And you can retreat easily if you do have a recurrence. You just have to basically treat the levels above and below and have them fill in that venous plexus, in the location of the fistula. Overall, 2% of patients are sent to surgery. So here's the patient, pachymeningeal enhancement, no brain sag, but venous sinus engorgement. There's a fistula right there. After I treated him, he was kind of better, but he still had pachymeningeal enhancement, which meant that he still had a fistula. And you can see here that there was subtle leakage of contrast that's coming out here. You can see it's actually not coming out it doesn't come out from the diverticulum, it comes out at the neck of the diverticulum, so it's coming out here. So I treated the epidural plexus in the patient, as well as the levels above and below. and then brain MRI normalized, and everything's much better. Having multiple fistulas is common, so it's development of new fistulas. Around 21% of patients we see have multiple fistulas at baseline. After treatment, 10% develop new fistulas at remote sites. Risk factors include multiple nerve root sleeve diverticula, longer duration of pretreatment symptoms, and rebound intracranial hypertension. You can see here this patient's got brain sag, pachymeningeal enhancement. She'd been suffering for the disease for 20 years, had 4 fistulas that were previously treated surgically. And then 4 years later came to us with recurrence of symptoms, and she had um, 1, 2, 3, 4 new fistulas. So what we did with her was we treated 3 of the fistulas initially, and then we treated the last one um, after like a month. And we started her on Diamox before treating the last one because we didn't want her to get rebound high pressure and get recurrence of symptoms. My personal record of number of fistulas seen on a myelogram is like 12. When that happens, I don't treat every single fistula. I just treat like a few of them, see how the patient's doing, and then if they're better, we don't treat anymore. One of my colleagues just sent me a case where a patient had, you know, uh, it sounds crazy, but the patient had like 20 definitive CSF venous fistulas, and I couldn't believe it when I saw the case. He was right, and that those patients are very challenging to manage. So this is the patient after we treated her much better. And then lesson number 10, a lot of bilateral chronic subdural hematomas are caused by CSF leaks. So about 30% of SIH patients have subdural hematoma. They're always bilateral, but sometimes asymmetric. This is a very nice study from Korea. They looked at 60 patients with non-traumatic chronic subdural hematoma. They found CSF leak in 80% of them. It was more common in patients under 69 years old. Interestingly, only 25% had orthostatic headache. So we're starting to see more and more patients, chronic subdural hematoma. We do MRI brain, diffuse pachymeningeal enhancement, or they might fail conventional management, and then we start looking for CSF leak. This is the article from 2014, Jürgen Beck. They had 27 patients under 60 with chronic subdural hematoma. CSF leak was found in 26% of them. And this is before DSM, before we knew about CSF venous fistulas, but multiple diverticula, which I think is a secondary marker of CSF fistula, was seen in 44%. So now we're managing patients with subdural hematoma and CSF leak completely endovascularly with combination MMA embolization and CSF embolization. The last thing I'll just say is that this is a very rewarding part of a practice. We get letters like this all the time. Our patients are very grateful. This was a gentleman that had full-blown frontotemporal dementia. They were about to do a tracheostomy and PEG tube on him. We treated him for a CSF leak. Within 2 weeks, he was completely back to normal. Within a month, he was back to work. So that's it for me. I'm happy to take any questions. Thank you.
Okay, thank you very much, Professor Waleed Brinjikji. It's also a very nice talk, and maybe lots of questions from the audience. The first I have to do. By the way, so during the embolization using the onyx transvenously, right? But
Yes.
I don't see any chant, from the image. I mean the venous image, right? No chanting point.
No.
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 So just you guess, where is the chant over there? So based on the myelography.
Correct.
Uh, so the from the beginning, maybe you decide which part you should, the inject onyx, right?
Yes.
Oh, okay. So,
Yeah.
by the way, the injected onyx is stay in the vena side, only vena side, or pass through in the cerebrospinal fluid space.
Yeah. So we do CT scan on
Mhm.
almost all of our patients after
Mhm.
treatment, and I've never seen intrathecal or onyx in the CSF space.
Mhm.
So the
Okay.
shunt must be very, very small.
I see. So it means the only venous side they inject the onyx that occludes that whole fistula.
Yes,
Oh,
I think
very
so.
nice. Yeah. By the way, we have two discussants. And first, the Professor Tsumoto Tomoyuki. Yes. Do you do
Oh,
that?
thank you. Yes, thank you very much for excellent lecture. Also, we don't have any experience like your procedure. I have a question very similar to your Dr. Hyodo. So, how
Mm.
do you determine the extent of the venous segment that need to be embolized during the surgery?
So I basically, if we know that the fistula is at right T10, for example,
Mm-hmm.
I get my catheter position at right T10,
Mm-hmm.
and I just keep injecting until I think the whole venous plexus is opacified. So what I do is I can show this. Let's see here. So when I look at an embolization, maybe. So ideally, my ideal embolization
Mm-hmm.
um, is something like this one, where I have onyx in the epidural plexus, I have onyx in the intercostal vein, I have onyx in the paraspinal vein, and I have a lot of onyx in the foraminal vein. And I see a circle here. And this circle is the venous plexus around the nerve root. So the nerve root passes through that circle. So if I can get all of these with the onyx injection, then I'm confident that the fistula is completely treated because I've treated every single venous segment in the neural foramen. Now, with onyx, as many of you can't predict what's going to happen with the injection. So occasionally, you start getting too much reflux, or it's all going out the intercostal vein, or too much is going into the epidural plexus. And at some point, you just have to stop because it's not going the way you want it to. But I would say that typically per level, I use 2 to 3 cc's of onyx. And this is because the venous system is has a high capacitance. So the venous system can dilate, unlike the arterial system. So you can keep filling it up before it's completely full.
So this picture is just one level, but I can see your slide from your slide 2 or 3 level. You inject on it. Oh, go right
Yeah,
thing. So
yeah.
this
Okay.
multiple shunt or single shunt.
Yeah, so this was a patient that um, basically what happened was the fistula was here, and we started injecting onyx here. So you start injecting, but then sometimes the onyx starts going up and go
Mhm.
down before it fills the foramen. So sometimes you have to be very patient, so
Mhm.
you can start injecting from here, and the onyx will go up, and it'll just
Mhm.
keep polymerizing here, and you wait, you keep injecting, and it keeps filling the level above, and then you push here and it keeps going the level below, and then eventually it gets to your level that you need to treat. So I would say that a lot of my onyx injections, like, they look like this mainly because of how onyx behaves.
Ah,
um yeah, but I would say that we can fill a lot of the epidural plexus
mhm.
with the onyx, and the patients do not experience any neurological deficit because there's so many options for venous outflow in the spinal venous system.
Okay, thank you. I see. I see. Thank
Okay.
you.
Any more?
Uh,
All right. Thank you very much, Professor Tsumoto. So next time, Professor Tanabe, please make a discussion.
Thank you for your excellent lecture. So, but I don't have any experience for CSF venous fistula. So I learned this disease through your lecture. I sometimes experience the intracranial hypertension or CSF leakage. The main cause of the CSF leakage is CSF leakage to epidural space. So we often treated the a blood patch to the epidural space for this patient. So
Yeah,
so
I think. Oh yeah, continue, please.
sorry. So what percentage does the intracranial hypertension cause the CSF venous caused by CSF venous fistula?
So it's very interesting because where we live, I would say that 90% of our CSF leaks are fistula. But when I do look at the literature from East Asia, Japan, Taiwan, Korea, and China, it does seem that the majority of CSF leaks are caused by dural tear. And it's an interesting association. Now, is that what I would say is that if you looked at patients in the US 15 years ago, it would also look the same, that everybody's leaks are dural tears, and there's no such thing as CSF fistula because we weren't looking for them. So the question is, how often are you or others investigating for CSF fistula in patients with brain sag, or is it mostly just looking for the dural tear? So in our population, I would say it's 80%. It's possible that it's different in Japan, Korea, China, Taiwan, etc.
Okay.
Thank you.
Okay, now Professor Tanabe, no more?
Thank
No
you.
more?
Oh,
Okay,
yes, thank you very
Thank you
much.
very much. By the way, Professor Brinjikji, you told during your whole patient, maybe only 5% was no change after procedure, right? So
Correct.
for that particular case, will you do that, myography again and check again and maybe the treat again?
Oh yeah, yeah. I mean, for a lot of these patients, we'll do myelography again, and sometimes we find a new fistula, or maybe a fistula that wasn't there previously. Sometimes we see the recurrence. Sometimes even we retreat and there's still no change, and they keep coming back for myelogram. So we have some patients that come for repeat myelogram 5, 6, 7 times looking for the new
Oh,
fistula.
really?
Yeah.
But then the diagnosis is the most important, I think, and yeah, otherwise we can't do anything, treatment.
Yeah, that's the most important thing. Yeah. And I'm very fortunate because in my department, we have 60 neuroradiologists, and 12 of them do myelograms to identify CSF leak.
Oh, really?
So I'm very fortunate. So I don't have to do the myelogram anymore. But
Yeah, if you
what
do
I
that,
tell
then you're too busy.
yeah.
Yeah.
But what I tell people is it's very important to have a good team and good relationship with your radiologist who will do the myelogram.
Okay, thank you very much. This is also, very interesting, the procedure, and also, completely new concept. So please continue to do and, and please teach me later more. Thank you
Thank
very
you.
much.
Please. And any of you are welcome to visit anytime Mayo Clinic, and we can show you how we diagnose and treat the patients. It would be a privilege and honor. And just email me and anytime. Thank you.
Thank you very much. By the way, Brother Joy,
We have
almost
Sensei
time.
Prof. Kato
Yeah.
with us. Prof. Kato.
Professor Kato is here?
Yes.
Join? Okay, please.
Please unmute your mic, Sensei.
So that's really, thank you very much for the two great teachers that taught us this very nice lecture. But unfortunately, I could not listen to the nice lecture because another webinar just finished. So, but I think this very advanced treatment is very fortunate, I think, in the future.